All right, General Hara, thank you so much for joining us today and giving us an update.
Yeah, it's been a while. I really appreciate it.
And appreciate your time to give this to us at KITV4. I wanted to get your sense, because it's been almost 6 months since this pandemic response has launched. You were named as the COVID response head. What's your assessment? What grade would you really give us?
So I think first off, when this thing started, we had a grade of A, right? We were one of the best, if not the best, in the nation for a very long time, for several months. But as we started to open up, we saw the virus starting to spread. And what really caught us by surprise is how quickly the virus grew exponentially, all of the infections. And I think that's what caught the Department of Health by surprise. And, a lot of people were concerned. We were concerned. And obviously, we did not have the requisite number of contact tracers or investigators that we told we had sufficient numbers on. But we rapidly, reorganized and looked at what the problem was, brought on Dr. Emily Robertson as the lead for the disease investigation branch. And what she's done is she created this new category, right? So everybody's saying contact tracer, contact tracer. It's more than that. It's really the disease investigation operations. So she created this new category called first contact callers. And why that's important is it's easy to train these people up quickly, and they can get after the target goal of getting the index case within 24 hours, and then reaching out, identifying who their close contacts are, and then doing the investigation or doing the calls for the close contacts. And so again, so the index case we want to get to within 24 hours, and then any close contacts within 48 hours. We're still a little bit behind on that. We've cleared up over 2,000 cases just with the National Guard contact tracers that we brought on. So what we call it in blue skies, right? When you don't have an investigation in the disease investigation branch, that investigators, they do everything. So they did the contact tracing, they did what's called contact monitoring, case monitoring, and then case investigation. So all 4 of those were done by a single person. And obviously we had multiple investigators. But what Dr. Robertson had done is she split out all those responsibilities. So for each of those categories and responsibilities, she has separate people doing it. And that's how she was able to get after, reaching out to people. Once we know that they're positive, reach out to them and start the investigation going. And they're still ramping up. Right now, they're training up 30 people. We were coordinating with the city and county of Honolulu, so we'll be bringing on 30 additional first contact callers. She's looking at increasing her capacity for both contact tracers and then also the contact monitoring specialists and case monitoring specialists that I talked about. And in the long run, she also wants to increase her case investigator capability as well. That one is the toughest to fill, because that one needs the most qualifications. You either need to be an actual investigator or an epidemiological specialist.
Well, and that's so important. I know we've been having these discussions over the last few months about how all of this restructuring needed to happen perhaps sooner. So now that it's good that it's happening now, but I guess looking back, was there something that we could have done differently? Could we have moved a little bit faster? What were some of the roadblocks that you feel? I mean, frankly, was it a result of the change in leadership at DOH that they were able to kind of relieve some of this bottleneck that we all been complaining about?
I think that's part of it. I mean, I don't want to look back too much or point blame, right? I mean, Dr. Park was like an expert in her field, and I still consider an expert. But I did recommend a few times that, hey, maybe we should get these people trained up and just leave them on the shelf. And that, when you need them, they're there. Break glass in case of emergency. And luckily what we did is I actually had our National Guard folks go through the training and be prepared. So when the call did come and they realized, oh my goodness, this is a lot worse than we have ever anticipated and how quickly it happened, when we got the call, within one day, we had a few people in there helping them with administrative stuff and trying to get organized. And I would say within 3 days, we had contact tracers already making calls. If we didn't anticipate needs, we wouldn't have been that responsive. So from early on, I put this out, and I think I even said this in my first interview I ever did as the incident commander. I said, we are in, this disease, this outbreak has put us in, a crisis that we got to move at the pace of unprecedented crisis. We got to look at different ways of doing things. It's not the normal blue skies type of operations. So to be able to do that, we need to be responsive. To be responsive, we got to anticipate needs. And then once we know what those needs are, then we organize and resource and be prepared. So when the request comes, they're there and ready to go. And that's why we have been successful for a lot of things. We created these COVID swab teams and go on. So if there's a cluster, we can send these medical trained specialists that can do the nasopharyngeal test, the PCR testing. That's the gold standard accurate, right? And if we weren't prepared for that, then we wouldn't be able to respond to all these different clusters.
Yeah, and the other thing too is now that we've seen, 6 months of this kind of going from being the success story of the state to being kind of the what not to do in response, how are we going to rebuild the trust? The public has really lost trust in what the state has been doing. And, going forward, it's up to you and the rest of the team to really rebuild that.
Right. So, when we had our conversation earlier, you talked about transparency. And it's really about communications, right? Communicating what our priorities are, what are we doing, and the plans and future planning and everything else. Because if we work in vacuums and the public does not know the great things that the people throughout the state and the counties, the first responders, all the great things that they're doing, if we don't share that, then they lose confidence. I think the first step was, like you talked about, there is leadership changes at the Department of Health. Dr. Libby Char is well respected and very, very qualified. I think you're going to see great things. We created and we're building out what's called a pandemic unit. So what's really different is we're going to separate that pandemic unit out from the core Department of Health, and they'll be reporting directly up to me as incident commander. So, what I used to always say is I used to ask DOH for stuff. Now I can actually task DOH for stuff, and that'll make it a lot better. I think you also saw that recently the state launched the dashboard. It has the critical things that we're measuring, the metrics that we're measuring. And that's another way, right? So people can go in there and look at it, saying, well, what is the hospital beds? They don't have to wait for the lieutenant governor's early morning briefing and his little whiteboard. Now there's a professional dashboard out there that's real time. So,
yeah, because as you mentioned, data is so important, and people have been really wanting all of this data
right.
for a long time. So
and it's got to be accurate, right, and non-conflicting. So I know there's some other pages out there. I think the House, they created this COVID-19. What was it called?
COVID POW.
Yeah, COVID POW. Right. And we just got to make sure it's good they're doing that, but we just got to make sure they're pulling the same data so the public doesn't get confused.
Yeah, I was going to ask you about that because now we're seeing so many of these dashboards come out. I also know that you guys had another kind of resources, this Kokua offers, like some of these other types of resources for people. So how do you, I guess, make sure everyone's working toward the same goal and not be confused by all these different initiatives?
Well, what we're hoping is to have like a master site, right, that people can go to, and then they can click on a link and then go to the other database of record. But at least have one or two official sites that's the repository for the official information. It's similar to, like, if you have a hurricane, the National Weather Service is the source, right, the official source. But yet all the TV stations have their experts, they're doing their own reporting. And so it's the same thing. We can't stop that. And, in honesty, it's healthy, right? People are comfortable going to places that they trust.
Mm-hmm. Okay, well, that's good. At least that's the data is coming. I wanted to ask you about the airports, because I remember before, a long time ago, it feels like such a long time ago, when we were talking about how to handle visitors and arrivals. And now, we got the news about the U.S. Lifting the restrictions on travel, international travelers, not requiring health screenings anymore. What's your take on that? I know we've kind of not had enough international flights anyway, but we still get them.
Right, very, very limited. And a lot of them are chartered, so it's easier. So for the state, we're primarily focused on the Trans-Pacific travel. So they'll arrive, and then they get screened by the Department of Transportation Airports Division. They have people that'll screen, verify identification. We launched a new Safe Travelers application, registered. That thing's going really well. So this person comes in, they have the QR code, our people scan it, all the information comes out, and they validate certain things, right? Validate that is a person, validate that they have lodging reservations, validate that their phone is working. And then once they meet all of that criteria, then they're able to go to their place of lodging and then do their self-quarantine. So the big deterrent of the mad rush of tourists is our self-quarantine order.
And so you would say it's working?
Yeah, I think it's working. Obviously, some people are coming here and not following it. And then, it's a combination of the local law enforcement and the state attorney general's investigators that are doing the enforcement.
Mm-hmm. And we had been talking also about this testing program for the longest time, right? The pre-travel testing program that keeps getting pushed back. Is there any update for that?
So I know right now it's 1 October, and the state is really trying to push that forward. Governor's having a meeting this weekend with community leaders, and I think he'll be making an announcement shortly. So it'll either be, yes, it's 1 October, or we need to push it right. And he's going to go set firm on a date, and then I'm pretty sure that will be the date. Whatever comes out at this press conference will be the date.
Mm-hmm. And just to clarify then, so for example, because I know that Philippine Airlines still has its international direct flights from Manila, so they will still continue, you will still continue having the health screenings, even though the US had said that you didn't need to do those anymore.
Correct. We will continue.
Mm-hmm. Okay, that's good. And I know we have the thermal screening at the airport, like they installed the technology already, right?
Yes. So there's cameras that does the face mapping, and then there's one that does the thermal screening. And then if anyone has 104, 100.4 and above, then the person at the monitor will flag, and then they'll notify, they'll get that individual, say, hey, wait here. They'll notify AMR, who has the contract. They'll do a second testing with a different device. If their temperature is lower, then they're free to go. But if it's still above 100.4, then there's an algorithm that was set up by Department of Health that will be followed.
Okay, so at least that's already in place.
That's
So
in place and has been in place and has been working all this time.
okay, great. And then the other thing that we talked about was the economy and tourism, and just kind of in your strategy going forward as we, try to manage these outbreaks, especially I know you've also worked on the federal response units, medical units coming in.
Oh, yeah, I forgot to mention that.
Yeah, go ahead. Giving us an update on that.
Success stories. So, the hospital started saying, hey, our beds are filling up, ventilators okay, but not so much the beds. We got the rooms, especially Queens. We need staffing. So we had, rather than piecemeal it, we had HAH, Hilton Raytheon, and his group get with all the different hospitals and say, what is the requirement? We tried to solve the problem in-house, like see if we could contract. We have to do certain criteria before FEMA would even consider our request for assistance. And once we met those benchmarks, submitted the formal RFA, and then because we had been pre-coordinating, within days, all of this healthcare specialists started to show up. It was pretty heartwarming because when the first group went out at the Queens Hospital and all their key, people, the executive leadership, and then some of the healthcare workers in front, and then when they saw the federal nurses and doctors show up, they just started applauding and cheering. It was pretty awesome. It was too bad that we didn't have actual video out there and caught that. That was
why didn't anyone tell us? Was it a secret mission?
I found out that day after the fact. I was like, what the heck? And then luckily, Queens had a photographer there, so we were able to get some pictures.
Yeah, we saw
Yeah, that was
those.
a huge opportunity. That was a huge success story.
Yeah, this is what I'm telling you. You're not promoting it enough,
Yeah,
you know?
yeah. That
Well,
was my fault.
was it because was that something under your agency? Was that under your agency that you guys spearheaded,
Like I
or?
said, so many people, right, working at, but it is Hawaii Emergency Management Agency that puts in the request for assistance to the federal government.
When was
FEMA,
that actually? When did they actually come? Do you remember the date?
I don't know the exact date. I think about 3 or 4 days ago.
Okay, so it was
But
last
they
week.
came in, yeah, they came in, they did a little bit of orientation, and then they're at work.
Yeah, because I remember seeing the press release on it, and then I remember thinking, why didn't we go cover it? But I guess no one knew about it happening. Is more coming? But is it separate from
Yeah,
the
yeah. So
helo though?
more so, they when I talked to HHS, Commander Kua, who's a lead rep here in Hawaii, he wanted to stagger it just a little bit because they only here for 2 weeks. So rather than stop, he thought, hey, if we stagger a little bit, at least we got some people a little bit longer than just the 2 weeks.
Okay, so but is that separate from the helo? You know, there's the group that's deployed to helo for the veterans home.
Yeah, that's
Is that a
totally
separate? That's a
yeah.
totally separate group. Okay, got it. Because I know there was
So it's a
Shots was
combination
pushing
of
that.
inspection and an assessment to see, what happened, what went wrong, what needs to be taken to move forward to ensure the safety of the people, the staff, and the residents, right? At
Hmm.
the Kyokuts long-term care facility.
So they're here for 2 weeks, and then you'll maybe have another group coming in. Is that the plan? Like
No,
staggering?
the other ones will be arriving shortly, so it's not like start stop. So it's not going to be like 4 weeks. It'll be an over.
Oh, there'll be some
Right,
overlap.
right.
Oh, okay. And will they all be at Queens, or are they going to be at different hospitals?
So right now it's Queens and Kuakini, but I don't know if there are any other breakouts. There's only two that I know of right now.
Okay, and that's managed. How they choose that is by HAH.
HAH and
HAH.
really in coordination with HHS because HHS is the overall. Um,
Overall group. Okay, that's good.
There's an incident management team, IMAT, that came in that kind of they have their own public affairs as well. But this small leadership team is kind of directing where these doctors and nurses go.
Okay, well, that'll be good. When the next group comes, maybe we could get a heads up for when they arrive. And then so going back to the economy and tourism. So what's the overall strategy to get that? Because of all the closures, as you know, on Oahu, businesses are just, really struggling without the tourists and not being able to even open for Kamaina. So what your
The
sense?
city and county of Honolulu has been working very closely with the state. We'll be revising that chart. Remember, you guys had like red, yellow, green. That's going to be revised, and the city will take the lead on announcing that, I believe, early next week. So I don't want to get ahead of them, but many hours are put in to get this new plan out.
So that's really
Also,
the economic part of it is really left to the county.
not so much the economic. There is a state disaster recovery coordinator that's Ali Sloas that works for the governor's office. And then, the governor still has Alan Oshima, who's the navigator. So the two of them, along with DBID, are the lead for getting the economy open. And then really what's next, right? The beyond recovery, how do we build resilience so we're not as dependent on tourism?
Yeah. Honestly, though, I feel like I have not heard from those groups. And I think the public doesn't have enough information about what they're working on. Again, this transparency that we talk about, right?
Yeah.
I don't think people feel like
So they
anything's
came out,
being
when we
done.
first did the Beyond Recovery Plan, they came out, we did all the formal briefings, they briefed the plan. But we do need to modify that because now it's not going to be aligned to what the county is working on. So there'll be some major changes to our charts to make sure that people don't get confused. Different colors and what opens for what. So we got to modify our plan too. Since the county is coming out with theirs, and then I'm sure as soon as Alice Lois and Alan complete updating their plan, then we'll start launching some additional press conferences.
Okay. Yeah, because I think that hasn't been really talked about as much before, um, the businesses and their impact. And the PPE, I know you had this, I saw this release you had about this free PPE program. How's that? Do you know what I'm talking about?
No, I don't.
It's gosh, I just saw it, and it was about like a free resource where businesses or small businesses or
Oh,
hospitals
okay, yeah, yeah.
can
So that's
get free
the
PPE.
PPE that's related to Act 9 of the CARES funding. So we
Okay.
received $61 million, which what we're purchasing different PPE. The problem is we weren't able to buy industrial hygiene products. So that's why the governor had to line item veto a portion of that CARES Act line. So when the funds are, we believe, will be released on 15 September, then we're going to give those funds to HIEMA, and the state procurement officer can start purchasing these supplies. So there is a website. If you fall within those categories, there are priorities, and then you put in your request, and then HIEMA manages that, and then they'll do the order and then do the distribution
And
through the group,
anyone can apply? Is it
as long
like
as they
what?
meet those requirements.
Okay.
I
And it's
think it was
all on that website,
small
right?
businesses was like 50 and less, had the the nursing care homes, medical facilities, and then the hospitals was the top priority.
Okay. And that was all federal funding as
Yeah,
well.
the CARES funding, correct.
Okay. Well, yeah, so I think that was it for for the notes that I had, but I just wanted to get a sense for you, give you a chance to give us a look at the strategy going forward, from your end. What will the priorities be, since we're seeing that it's not going to end anytime soon, these shutdowns that we have?
Right. So what will happen is we need to figure out how we can open up safely. I think, you said, how do you grade yourself? As we started opening up, probably we moved a little too quickly. And to be honest, a lot of us let our guards down, right? Large parties and stuff. And I'm not placing blame, but in reality, if everyone followed the safe practices, right? Wearing a face covering, trying to keep your social distancing if it's not in your family unit, not doing these large parties, uh, the virus wouldn't have spread so rapidly. So I'm hoping we as the community learned our lesson. I hope that as we reopen, it's really structured and we stick to the plan that we said we're going to do as we reopen, and then we monitor. And then if everything's going good, then we open some more and then monitor and then open some more. So if we go with that and really looking at targeting, hey, what do we close? I mean, if the virus isn't spreading, what is really unfortunate is because we had the wide community spread, a lot of the people that were interviewed, we couldn't figure out how they got infected. I mean, you think about all the times that you caught flu, huh? Do you really know when you caught the flu? Probably not. It's hard. That investigation and the contact tracing we're talking about, it's really difficult. So as the amount of people that you cannot make a determination of how they got infected, then you don't know. So we cannot just say like, well, I have this type of business and there's not a single cluster from this business. It's hard to prove that because we don't know. Maybe there were infections tied to that.
Should we
So
have a law that requires them to disclose that?
as far as no. So people wanna disclose, but you're looking back, even me about probably 2 months ago, I started feeling sick. I was like, man, I'm like really strict, right? I stay 6 feet away. I live in my office. I still live in my office. No one can come upstairs unless they have an appointment. And it's very rare that we even let anyone in our bubble. I have my own bubble in my building on my floor. Even the coworkers cannot pass a certain area. And I started feeling a little bit sick. I was like, what the heck? So I pulled up my calendar, which is by hour. And I know most things were virtual, and then there's certain people that, maybe I went somewhere and I know exactly who they were. And I don't say anything. I was like, I wonder if they got sick. And they're like, oh, no, nobody else is sick. I was like, oh, shoot, how did I get this? And I just felt kind of crappy for a couple of days and then I was okay. But it's hard. Even with my detailed calendar, I couldn't figure out where if I caught a cold, where I caught it from. It's pretty tough.
Well, and that's what I'm saying. I think that's why so many people were disappointed that um, we had dropped the ball on that kind of investigation part, because we had been so far ahead of the curve for
Right. Yeah,
several
you want to
months.
rapidly identify and then isolate, right?
Hmm.
So yeah,
What's your sense of the surge testing and where we should go after now? Because they're leaving, I think, on Monday, right? That program ends.
correct. So the Department of Health has a strategy, and it's not just the search testing, right? It's other testing as well. Um, let me pull up. I have my. I think I put some notes on that. Hang on, please. So there's diagnostic testing. So that's where somebody is sick or a close contact, right? You can go out there and do diagnostics. There's also broad based. So let's say we have a cluster at OCCC as an example. Then we say, hey, we're going to test everybody there. Then you have the point of care testing where the federal government is pushing these devices down. So like the high risk um, establishments like long-term care homes, that they can do continuous testing. And then we have this wide surveillance testing. So the Department of Health has a strategy now. I read through it, but now we got to operationalize that, right? This is like high level, but how do you really do the testing? So that's the part that we still got to work on. The real big challenge is some great advancements in testing. There's this Abbott Essex where you get the test kit and then you do a saliva test, and then you don't have to send it anywhere. That cartridge will tell you if you're positive or negative, and you have a little thing you can scan, and then it'll get reported. But the federal government, HHS, bought up all of it, 150 million of them. So now the states cannot get access to these tests. But there are other, antigen tests, saliva-based that we're looking at. But it's really going to be dependent on the local vendors and their supply chain, right, to be able to do that type of testing.
Yeah, and just really the attitude, do you think it's changed? Because we were really strict on who was able to access these tests on the diagnostic level. Do you think
Yeah, I
that,
think for the diagnostic, because that NAAT, the nucleic acid amplification test, everybody says the PCR, the one goes to the back of your skull.
yeah,
Down there, you need qualified people, burns up a lot of PPE, and it's limited in capacity, right? I think, over 5,000 now that we can do per day. So if we burn all of that up, it'll probably be wasteful. Some of these other new tests that I mentioned, the specificity rate or the accuracy is really up there. Some of them in the above 90% now. So if they start mass producing this and getting this to the States, it'll be a lot better for us.
okay, so that would really help us ramp up more of these community-based testing
Correct.
programs, because I think
Correct.
that's been the complaint ever since, just like the communities where they need them have not been able to access them. So, and then we saw that with Kalihi, because
And
I
then
know,
if we see a potential cluster, though, we do send that SWAT teams, the mobile SWAT teams that I mentioned, right?
that's been going on
We,
for how long? That swab team. It's like
we
SWAT, but swab.
yeah, I think over 2 months ago.
Okay, so it's been a
Yeah.
couple months that you've
So we
had
did all the
this.
KPT and some of the other clusters.
Okay, so that's good.
And
Because
then
I
we
think,
did OCCC, that was about 1,000 people, and it actually did a second round of testing. So that team tested over 2,000 people.
so that's your team that goes in and does all that when
It's a
there's,
combination of my team, my guardsmen, so both National Army Guard and Air Guard, soldiers and airmen, along with Department of Health. It's a joint team.
and this is the one where they test everyone, right? Regardless of whether they have symptoms or not. It's just the
Right.
fact that there's a cluster there.
Yeah, the wide base. If there's a cluster, more than likely you are a close contact, and boom, you're getting swabbed.
Okay, yeah, because I remember there was one at the public housing complexes, and they weren't testing everyone. They were just testing symptoms. So I was wondering why they did that.
Was that early on?
Yeah, I think it was early on. It was probably in May or June.
Yeah. So maybe
But
the initial when they went out there, just do the symptomatic ones first, but then based on their results, then you do the close contact, and then we come back in again to do the close contacts.
Yeah, but the problem is the DOH wasn't keeping up with the contact tracing. So,
Right. Yeah.
so it had already spread. So that's why people were always saying, well, why don't we just go ahead and blanket test everyone in those places anyway, because they're not keeping up with contact tracing.
So at the time was, you know, because of the constraints that we had, right? If you, for that PCR test, it could be the supplies itself, the actual swab and the transport medium, or for the people that's doing the swabbing, do they have the appropriate PPE? And then when we get it to the lab, are they the right amount of tests? And then, you know, there's reagents, right? And then now this pipette tips. All of this, any one of those supply chains, if there's a problem and then we stop testing, that'll be even worse than not going out there and testing the high priority cases. So we kind of ebb and flow and watch our supply chain to match our ability to do the testing.
Mm-hmm. But you're hopeful. Are you hopeful?
Yeah, we're very hopeful. You know, we continue to order supplies, PPE. We ordered supplies for to do the testing as well. The Department of Transportation Airports is going to use CARES funding to buy additional instrumentation for the big labs so that they can even do more testing in Hawaii. So we're trying to build capacity.
Okay, well, that's good because, again, I think there's so much distrust or lack of confidence now. I think it's at a low.
Right.
So if
yeah, it's going to take time for us to build the trust again. But I mean, that's why we're here, right? That's why we're in the positions that we are. There's ups and downs.
Okay, well, I appreciate it.